let's switch to some audience questions for a bit. I've got some cards here. I don't know if there are microphones set up.
There is a microphone if anybody.
Okay, if anybody. Okay, so people want to go and ask.
Just flag me down and I'll bring it to you.
Okay, sure. Do you anticipate that some ACA exchange plans may become de facto high-risk pools and unravel due to the high premiums and dropouts from healthier consumers?
I'll take that one. My observation of what's going on right now with the exchanges is that there's a dichotomy that's happening with the Medicaid plans and what the diversified large insurers are observing as far as adverse selection and what their profit margins look like. And if you ask Centene or and Molina and HealthNet, they will tell you it's because they are better at pricing and they did a better job of pricing appropriate with the health risk. But that seems really hard to believe that United and Humana and all did not do that so well. So I think that the lesson to be learned to some degree here, and we'll have to observe what happens, is that the premium and the cost-sharing subsidies for exchange-eligible enrollees up to, say, about 250% of federal poverty level, which is where the Medicaid plans target their efforts in the marketplaces, because they want to make sure that they address churn between the Medicaid population and when they get part-time jobs or whatever in exchanges is likely to be a functional marketplace. They also have a better cost structure because they're building it off of Medicaid networks in low-income neighborhoods. It's also their way of ensuring that people that don't make above $50,000 and are expecting to overuse and have inadequate subsidies enter that marketplace. Between kind of 250% or 300% of federal poverty level to about 400% of, toward the end of that exchange spectrum, that market right now looks broken with where the consumers are relative to what they can afford. And I don't know whether any of you are thinking about or how that might play out in terms of any legislative action or whatever, but it's quite possible that that portion of the market, I think, ends up becoming more of a unstable, high-risk pool type marketplace.
Yeah, actually, let me just do a follow-up to that. To what extent in that 250 to 400% where the subsidies are modest, are we talking about what's really a market failure? Or are we talking about the fact that, healthcare has become so expensive that the subsidies just are not great for that population, and that this is a problem that's far broader than the exchanges?
Well, it's both, right? I mean, it's both a market failure or a policy failure, if you will. The offer to consumers in terms of the level of subsidy is and the out-of-pocket cost in the end is not great enough. The out-of-pocket cost is too much relative to the perceived value that's brought to the consumer from high deductible plans. Most of them are high deductible plans for pretty much everyone except for those with immediate care needs, which is the danger of where we're spiraling towards. Of course, having said that, we're going into a new year and to a new tax season. The penalties are moving up, and we don't know what the impact is really going to be at the end of the day. I think there's certainly cause for concern that that's not going to be enough to repair the risk pool. But we'll see. We've got another chapter to go here.
Good. Got a question. How do insurers view telehealth and telemedicine? Does it reduce or increase net spending? Do they require enrollees to pay high cost sharing? Do they think it improves outcomes?
If I could just, I don't think that what we've seen so far is moving the needle enough where the companies are talking about it and seeing it have material impact. Having said that, it stands to reason that it could have a real cost-lowering impact if you think about it as being something somewhat akin perhaps to the shift to outpatient on the hospital side, and clearly it has the potential to be that, but it's not there yet in terms of the scale. And part of that, I don't want to say all of it, but a piece of that relates to, I think, reluctance on the part of insurers to reimburse for those encounters at rates that would be adequate to bring widespread provider participation.
Yeah, I think that's a good point. My sense is that telehealth, the incentives have to improve for the physicians. I think they tend to be maybe a bit more resistant, just like you said, until those incentives get more aligned. I think it's going to be more gradual.
We actually have an audience question, so he gets to go to the top of the line because he's brave.
I didn't know that. I thought I'd be at the end of all the blue cards. But thank you very much. John Graham from the National Center for Policy Analysis and Forbes magazine. And my question is about provider-based plans. And I've read anecdotes, but I haven't seen good measurement that they are increasing subsequent to the ACA. And I'd just like comment on, will they succeed? My understanding is it's very hard to get the incentives right, and that's historically been the problem. Will they take market share? In which segment will they take market share, or will they fail? Thank you.
If I could just offer an opinion on that. Of course, you already have some provider-based plans, if you will, that are successful and have been successful for a long time. And Kaiser, if you can use that one as an example, Intermountain, Geisinger, and so forth. What has changed is the increasing availability of health plan members on a retail basis, meaning from the exchanges, from Medicare Advantage, maybe from private exchanges if those take off, although they haven't really thus far, where narrow types of provider-based plans can go after those members and make an offer that works for them and their families that really probably wouldn't work for a group sponsor that is trying to represent a geographically and otherwise diverse population. So to the extent we keep moving in that direction for more and more retail, there are going to be more and more opportunities for provider-based plans to make a viable offering, and some of them will succeed and thrive. Others, which maybe are still don't have the right pre-ingredients, or are, at the end of the day oriented around filling beds and driving utilization rather than coupling that with also needing to have a efficient cost of care. Those ones obviously are less likely to succeed.
So there are a couple of those examples. For example, North Shore LIJ has been very active in building their Care Connect product, and that's a very interesting one. One of the things that I would observe about where we see the provider-sponsored plans perhaps being a little healthier is where the provider has a lot of concentration of not only services in the market that will be in demand by the population it will insure, but also market share across all of those services. Because if you are a really significant player in the market, and if you are, and I think Matt hit it exactly, if you are understanding that the goal of the exercise is not to fill a bed, but is to provide the right care at the right time, at the right place, at the right cost, if that's your goal, then you're more likely to succeed. So what we're seeing on the for-profit side is very limited participation. I think all of the hospitals, with maybe the exception of LifePoint, has a managed care provider-sponsored plan in a market someplace, but they're very special cases. HCA is pretty adamant we're in the hospital business. We're not in the managed care business, although they have one or two here or there, because you sort of kind of have to. But again, HCA is still in the business of filling beds. They haven't moved off that. They just figure that everybody else is going to exit and they're going to be the ones left standing, because you are going to treat trauma patients in hospital ORs and beds, and they want to be the ones to do it. So it's a little bit, that's a little bit of a different play, but it's still vulnerable. with homage to Carl McDonald, I think he was the one who said, look, it's taken the managed care companies 30 years to figure out how to manage risk, and they still haven't gotten it right. The hospitals have no business being in the business. I think he said that here a couple of years ago. It's one of my favorite all-time quotes, but that's exactly right. It's a very dangerous game.
Yeah. On the not-for-profit side, I would echo what Sheryl said. You know, we're seeing there's certain not-for-profits, Presbyterian down in New Mexico.
Yeah.
It makes sense if you've got the inpatient, you got the outpatient, you're aligned or owned enough physicians where you have enough market presence in your market where
Henry Ford in Detroit, yeah.
You know, where you can begin to look to take on that risk. I think on the not-for-profit side, what we're seeing is many people are interested in it. They're dipping their toe in there, you know, looking over the long game. As you see further consolidation, I think the concern on the provider side is, well, if we do a better job of providing the right care in the right place at a lower cost, all that's going to do is those benefits are going to go to the employers and to the insurers. So we better get into that game. So like a Kaiser, we sort of align it. If we do a good job, we want to own that premium dollar. So the benefit that we can bring,
they have to stop being hospital companies, and they have to start being healthcare companies.
Exactly.
And it's sort of this concept of a margin indifferent healthcare holding company, which is sort of the Kaiser model. Where you don't care where the care takes place so long as you own the patient and some of the profits stick to you.
And I get the sense, Sheryl, that the not-for-profits, again, because they don't have quarterly calls, they don't have earnings targets that they have to hit, they generally have very strong balance sheets, are in a better position. They've been further ahead of the not-for-profits in terms of dabbling, kind of dipping their toe into some of these different areas and maybe looking to develop a health plan, whether they do that on their own or whether they do something on a joint venture basis with some of the
my sense is that they started worrying about standing in the two canoes of fee-for-service and fee-for-value a lot sooner than the for-profits did. And so, yeah, they may be ahead of the game. The other thing is the for-profits don't like to talk about anything that isn't, you know, fully baked. So it's sometimes hard to know exactly what's going on. But I think for most of them, you know, where I would expect to see any of these sort of innovative things going on would be, interestingly, Tenet, potentially in some of the Duke Life Point facilities, and possibly, and in certain of the HCA facilities, but it is not broadly based. They can't risk it.
Yeah. Something that Matt said motivates me to expand on it, that you know, when we first saw hospitals start health plans was the 1990s. And I think the expectation was that there were going to be a lot of HMOs with narrow networks that they would contract with on a risk basis and, or in a sense, offer those plans. And then when that all blew up, in a sense, the market for a hospital-owned health plan disappeared too. And some of the hospitals were able to run the plans well enough to keep them or to sell them for a good price to an insurer. But it seems now that the world is coming together again, where between public exchanges, private exchanges, Medicare Advantage, there really is an audience to recruit to commit to a hospital's delivery system.